Hello, everyone. Thank you for joining us. We were having a little technical difficulties, but we appreciate you joining us here. So my name is Lizzie Stewart, and we are pleased that you all could join us for this week's lecture in Volume 10 of our No Neuropsychology Didactic Series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the No Neuropsychology Board, as well as the No Neuropsychology Committee. Before we start our lecture, one of our main goals of No Neuropsychology is to provide free, high-quality didactic content to our audience. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. New to No Neuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through APPCN. Here are the disclaimers for this series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box in the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Janessa Price. Now it is my pleasure to introduce Dr. Janessa Price for today's lecture entitled Transplant Neuropsychology, Neurocognition, Pre- and Post-Solid Organ Transplant, and Opportunities and Interventions. Janessa Price, PhD, is a clinical neuropsychologist and associate professor in the departments of surgery and psychiatry at the Medical College of Wisconsin. She completed her doctoral training in clinical psychology and neuropsychology at the University of Cincinnati, clinical internship at the Boston Consortium of Clinical Psychology, now VA Psychology Internship Training Program, and a T32 postdoctoral fellowship at McLean Hospital, Harvard Medical School, specializing in neuroimaging and addiction. Dr. Price directs the Integrated Transplant Neuropsychology Clinic within the MCW Solid Organ Transplant Program, which provides neuropsychological evaluation as a component of the biopsychosocial pre- and post-transplant and translates findings to individualized recommendations to support patients' healthcare. Her research program explores neurocognitive functioning associated with end-stage organ failure, addiction, and health literacy among solid organ transplant populations. Dr. Price also serves as the chair of APA's Division 40 Interest Advisory Committee. Thank you, and please help me join me in welcoming Dr. Price.
Thank you, Lizzie, and thank you, No Neuropsychology. I'm absolutely thrilled to be talking about transplant neuropsychology today. I often, when I discuss aspects that we'll get into today with my transplant colleagues, like to joke that I much prefer talking about the brain. It's a lot of other organs that come up in conversations here. So I'm glad that I'm in good company. Again, I'm going to be touching on really thinking about the specialty of transplant neuropsychology today and what that means for us as neuropsychologists. So conducting the assessment and doing those really solid formulations that we do, but also thinking about what that means for our patients' goals when they have end-stage organ dysfunction or failure and are thinking about transplant or in life-threatening need for transplant. So I hope this can be conversational and certainly encourage everybody to put questions into the chat so that we can continue these conversations after my slides. So to give us a little bit of a direction here, I'm going to start by talking about the pathophysiology of organ dysfunction and the impact on the central nervous system. I also will be tailoring a lot of the talk today with a lot of Transplant 101. So lingo, things to know, things that are important for a neuropsychologist. We'll then touch on neuropsychological profiles in end-stage organ failure and really what are those unique considerations by organ and by treatment. These are really complex populations. We'll then touch on neurocognitive risks and benefits in solid organ transplant. And then I want to introduce what this means for the field of transplant neuropsychology, an emerging field in terms of how we're phrasing it and talking about it, but something that's been going on for years and years and years, and certainly many, many other experts in the pediatric and adult realms who have been doing this work for a long time. So the lingo, you know, as you get...
Dr. Price, we can't quite see your slides at the moment.
Oh, let me see here. Let me share again. Is everyone able to see the screen?
Yes, looks good. Thank you.
Okay, thank you. All right, so transplant lingo. As folks who are engaged and doing medical neuropsychology, hospital neuropsychology know, right? You see all of these abbreviations in the chart and begin to start to learn that lingo. So I just want to walk through a couple things that will be important to consider. GFR for our kidney transplant patients, which gives you an indication of where they're at in their stage of kidney failure. When they're in that end stage beginning dialysis, there's two kinds, hemo and peritoneal, which we'll talk about. The difference between chronic kidney disease and, you know, what's now being termed end stage kidney disease, used to be renal disease. In liver, you'll need to know what MELD is, which is the overall sort of dysfunction number and rating that allows people to get to the top of the transplant list. Certainly hepatic encephalopathy and how we think about staging HE, and then other indications, so MASH or non-alcoholic fatty liver disease. Heart failure, we're going to be talking about transition into the advanced heart failure stage. And then different types of treatment options, the left ventricular assist device, as well as for some folks, a total artificial heart. Sleep apnea can impact all of these disease states, but certainly comes up quite a bit with heart and with lung as well. And then lots of indications for lung, primarily COPD or interstitial lung disease, and then FEV, how much they can exert in terms of their lung function. Okay, so this is really meant to give a little bit of a background about where staging occurs in lung disease or in organ failure and organ disease. And here in stages 4D, end stage, these end stages here across all the organ populations is where you might typically see patients who are undergoing evaluation for transplant. So we're going to come back to this. But really just wanted to kind of set the stage for, in terms of dysfunction and stage of organ failure, where a lot of our pre-transplant patients present. So let's start to think about how organ failure impacts the brain. We are certainly across organs going to talk about specific pathophysiologies, but there's some big ones that really cover the entire organ dysfunction picture. So regardless of that organ disease or etiology, there's widespread dysfunction in terms of neuroinflammation. So the small proteins, the cytokines that are involved in cell signaling to help control inflammation, they cross the blood-brain barrier and start to lead to neuroinflammation in the brain. There's oxidative stress that can happen, which can damage neurons, lipids, and proteins, all of which can lead to neurologic dysfunction. There's vascular issues. We will keep talking about this in transplant. It's a big part of neurocognitive etiologies, but there's increased permeability of the blood-brain barrier, which can lead to changes in blood pressure, which can increase the risk of stroke, and this idea of hypoperfusion. We're just not getting enough energy and oxygen to the brain. And then again, as I'll continue to mention as well for these populations, they are highly complex medical disease states with multiple comorbidities. So from a medical perspective, there's increased rates of things like diabetes, hypertension, psychiatric distress, but even thinking about other aspects of functioning, right? So these are patients who are going to have limited physical activity, nutritional deficits, and then back to psychiatric distress, mood and functional concerns, that all of which can impact cognition. So for liver dysfunction, what happens is there's an accumulation of toxins that happen in the blood. So there's ammonia, which is typically excreted by the kidneys after conversion to urea. Elevated ammonia occurs in liver disease and can cross the blood-brain barrier, and that can also eventually lead to cerebral edema. There's also manganese in the picture. And so this tends to be one of the presentations that people can have some familiarity with in the medical setting. This is typically excreted in the bile, but when the liver isn't working, there's an accumulation leading to deposits in the basal ganglia. And you can start to get some of the cognitive and hallmark features of motor dysfunction in liver disease, so the asterixis that can present. Hepatic encephalopathy is another cognitive picture that can happen. So certainly the asterixis that happens, but also these fluctuating levels of consciousness. So this is alertness, orientation, confusion, progressing all the way into really severe cases, you know, the patient needing to be intubated and sedated and concern for things like coma. And then when we're talking about liver, one of the etiologies to keep in mind for liver failure is the comorbid alcohol use that can happen. So the chronic and acute symptoms related to long-standing, often very heavy alcohol use, meeting criteria for an alcohol use disorder, again, often severe in presentation. When we're thinking about that from a neuropsychological perspective, there's certainly deficiencies when it comes to thiamine, managing withdrawal for folks who are coming down from their alcohol use and presenting in a medical scenario. Our teams work really well with that, so they're often managing those things preemptively. It's rare to see something like a Wernicke's encephalopathy or a Korsakoff's in the context of a transplant evaluation. But again, things that we as neuropsychologists need to be aware of. So as we discussed, the primary pathway to cognitive dysfunction and liver failure is through toxic encephalopathy and inflammation. So studies can show reduced gray matter volume and white matter quality in areas that are both cortical and subcortical. In the top image here is an individual with liver failure, and you can see there's hyperintensities in the subcortical white matter and periventricular white matter into the internal capsule and the midbrain. And then in this bottom image here, this is one of those pictures that highlights what manganese accumulation can look like. And so this is a different type of imaging picture, which is why the colors are a bit different. But you can see here in the basal ganglia, that accumulation of manganese showing up on the imaging. And interestingly, this left picture here is pre-transplant. Image C is showing us post-transplant. So you can see that some of that has attenuated over time as transplant happens, right? And then the liver function can return. So hepatic encephalopathy, I think neuropsychologists, particularly students and emerging neuropsychologists on the call, it's important to think about how we're staging this and what we care about as neuropsychologists in terms of how we're able to do our work. So when someone might mention hepatic encephalopathy in a medical context, they often are going to be discussing overt hepatic encephalopathy, so stages 2 through 4 here. And in the more overt presentation, it can range from mild to severe. Mild is going to even include more of that confusion, disorientation, difficulty with concentration. You can start to see the asterixis that's coming up here on the image. Those things, right, don't necessarily sound like it may be a great idea to do formal neuropsychological testing. If there's lots of fluctuations with hepatic encephalopathy that seems more overt. Now, in minimal hepatic encephalopathy, this is characterized as something that, you know, maybe an individual may notice, maybe not. Maybe family or collateral may have more insight into those really, really mild fluctuations. And we might see most of the kind of higher order cognitive dysfunction come up in neuropsychological testing when it comes to minimal HE. So encouraging our emerging neuropsychologists and neuropsychologists on the call to think about characterizing the work that they do, where you're really going to get bang for your buck. If we're going to do a neuropsychological evaluation, let's figure out that question. And if I'm able to answer it in the context of where someone's functioning cognitively in their liver disease. With kidney dysfunction, this is the accumulation of uremia. So all of the things that our kidneys typically excrete out of the body are now floating around in the blood and then eventually into the rest of our system. So the uremic toxins, urea, creatinine, and the nitrogenous wastes, they can cross the blood-brain barrier and lead to neuronal damage. Anemia can occur, which can also lead to reduced oxygen to the brain, back to hypoxia and hypoxemia. There's also dialysis-specific effects. So hemodialysis, which is typically through like a fistula into the bloodstream, you go into the center 3 days a week, that can result in lots of fluctuations in blood pressure, rapid shifts in fluid and electrolyte balance, which can also impact the cerebral perfusion. There's also this dialysis-associated encephalopathy syndrome that's been characterized, and it's most often kind of linked to chronic exposure to dialysis. Then there's certainly lots of electrolyte imbalance. So just thinking about the lab values that can present in kidney disease, how we read those, how we interpret them, lots of fluctuations when it comes to things like sodium, potassium, calcium, phosphate, and adherence. How much is someone adhering to the dialysis regimen, to the binders that they have to take, which literally bind to the food that they eat and pull out a lot of these things that cannot necessarily be absorbed and excreted through the body. So this picture showcases some common pathologies in end-stage renal disease. So image A here shows a chronic lacunar infarct and gliosis in the right basal ganglia. So this is something that we kind of call that silent marker. So it's neuroimaging that's incidental, but there isn't necessarily a clinical correlate. And interestingly, for chronic kidney disease patients, not necessarily those at end stage yet, this kind of neuroimaging finding is reported in about 32% of those pre-dialysis. So thinking about the patients I would see in the transplant clinic, many of these may already have some underlying neuroimaging abnormalities. Image B here shows degeneration and gliosis in the white matter, extensive in the periventricular zones, so we can see it here around the ventricles, and some really enlarged perivascular spaces in the brain. So we're seeing some degeneration, some atrophy, and also some white matter abnormalities. And then image D here is susceptibility weighted imaging, which is again why the color is a little bit different than what we're used to. But what the arrows are pointing to, those black areas, are actually cerebral microbleeds. So this is used to examine venous blood, hemorrhage, and iron storage. So again, a different picture, but representing some neuroimaging abnormalities that can be seen in CKD. These are of concern. These are the microbleeds, as well as the silent brain infarctions, are associated with increased risk of stroke, and that incidence can rise with the progression of chronic kidney disease into end-stage renal disease. So again, these patients that are coming to see us have significant risk from a neurocognitive perspective. Looking at heart function, there's a lot of things going on that can impact how the brain is working. So there's reduced cardiac output, there's hypoperfusion, heart failure is leading to that hypoxia and inadequate nutrient delivery to the brain. I explain it to my patients as, if your heart isn't working well enough to pump enough blood to your body and it's feeling tired all the time and having a hard time doing the stairs and the physical activity, that's also blood that isn't getting to your brain. And a figure that really helps kind of drive this point home is that the human brain weighs about 2% of our body mass, but receives 12 to 15% of its cardiac output at rest. So that really kind of showcases how much oxygen and nutrients the brain relies on. And if we're having reduced cardiac output, what can happen to the cognition? There's also endothelial dysfunction. So the vascular integrity starts to break down. That can be cerebral small vessel disease, the white matter lesions and microbleeds and lacunar infarcts that we saw on some previous imaging with our kidney patients. These kinds of things can occur as well. AFib increases the risk of thromboembolic events. So those are strokes or the silent microembolic strokes that can occur. There's also the hypoxia that can happen. So impaired oxygenation can result in neuronal injury and death. Sleep disorders. We talked a little bit about sleep apnea before. Heart failure increases the risk for sleep apnea. And then the reverse is also true, right? So if we're going to see not getting enough sleep at night and not getting enough oxygen at night, we also know that that can impact cognitive function in a negative way. And then a lot of what we talk about with our patients who have heart failure that progresses, potentially impacting renal function, kidney function, is a cardiorenal syndrome, which can exacerbate the cognitive picture. So to drive home those neuropathological changes in heart failure, this image examines gray matter density, or the brain density in the cortical brain regions between, on the top row here, coronary artery disease patients with heart failure, coronary artery disease patients with sufficient heart function, and then on the bottom row here, CAD patients who have no imaging abnormality shown. And then all of these groups are compared to healthy controls. And so what this picture is really telling us is, on that top row, line A, the CAD plus heart failure group has reduced gray matter density across the whole brain. So cortical regions, the posterior and middle cingulate cortex, and also within the subcortical regions, the thalamus and hippocampus, again, compared to the volunteer healthy control group. We don't necessarily see those differences in the CAD group without heart failure, or our CAD patients with sufficient heart function. So again, that's really telling us there's something about heart failure that's now leading to these neurologic changes in the brain. And with lungs, so the story with lung failure, as one can imagine, is this reduced oxygenation. So chronic hypoxia that can occur, leading to neuronal injury and cerebral atrophy, right? If we're just not getting oxygen, brain is dying off. Hypercapnia is something else to keep in mind. So elevated blood carbon dioxide that's caused by poor ventilation, which can lead to that hypercapnia and impair neuronal communication and function. Sleep apnea is coming up again. So there's an increased risk in our lung disease patients for sleep apnea. And conversely, this sleep apnea is also shown to worsen lung disease. So it's a bit of a reciprocal process. And back to poor sleep and sleep fragmentation impairing cognitive function in this picture too. And then there's also the direct CNS effects of these diseases. So if there's a CNS infection like tuberculosis that's causing the lung failure, that in itself can have direct effects on the CNS. Sarcoidosis is an autoimmune disease, and it can really happen anywhere in the body. But if it's impacting the lungs, one of the things that we care about figuring out is this also impacting the brain? And we'll touch more on that in a moment. So this picture highlights regions with cortical atrophy associated with COPD. So in a sample of COPD patients. relative to normal controls. So you can see some notable regions here, including the hippocampus in red and several aspects of the frontal lobe, kind of driving home that point, these higher order cognitive processes and related cortical areas being associated with lung disease in this picture with COPD. So back to our picture, in the transplant setting, when we're conceptualizing the factors contributing to brain dysfunction, we're really thinking about it in the end stages. For those of you who are practicing in more of the consult service or other sort of neurologic or psychiatry kind of settings, and you may see some of these populations in earlier stages, we'll touch on later how you as a neuropsychologist can impact on someone's readiness for transplant. I myself, in my service, see patients primarily here in the end stages who are being referred and evaluated for transplant. And the way that I think about that is, the most advanced presentations of organ dysfunction for our patients lead them to come to see us at this time. And they also have the most significant accumulation of neurocognitive risk and burden related to other comorbid medical conditions. So we're really seeing someone at their potential cognitive worst, at least at this time point of progression. Okay, so let's touch a little bit about neuropsychological profiles. And I'll just start by saying it's messy. So you can see here, we've got some arrows going up, arrows going down. We've got some side to side, positive and negative. A lot of this is really showcasing the literature and some of the gaps that we have in our understanding of specific profiles and how we're managing our understanding of that across other comorbid disease states. The global story that we can tell is that across these organs, the expected neurocognitive dysfunction is in fronto-subcortical processes. So things like attention, working memory, processing speed, executive function. For many of these, the memory dysfunction that we see tends to be related to primary learning deficits or retrieval-based difficulties, as opposed to something that's more amnestic. You can see a lot of the inconsistencies here in liver is that there's just a lot of causes of liver disease. So cholestatic disease, liver tumors, non-alcoholic fatty liver disease, alcohol-related cirrhosis. So there isn't really necessarily one pattern of neuropsychological dysfunction. Globally, hepatitis C is the most studied, and it's caused, the majority of the liver failure cases historically. We're seeing that shift. So now we're seeing non-alcoholic fatty liver disease and alcohol-related liver disease start to overtake that, particularly in Western countries. So it will be interesting to see how some of the literature continues to evolve with that. But a lot of what I'm hearing with that as a neuropsychologist is certainly we're going to see some cognitive deficits. There might be relationships with some of the etiology factors and comorbid diseases or pictures, but lots of opportunities for intervention with how we impact on lifestyle change and behavior management, abstinence from alcohol and other substances. So again, really thinking in that flexible way about how we can support our patients now and into the future. The other thing to touch on with this slide, I think, is that a number of studies are done, I'll make sure I'm highlighting it here on the right screen, are done using something like a global cognitive measure or a screener, or using something like a TRAILS-B and calling it global cognition, right? So I think we as neuropsychologists have a stake in ensuring we're studying this appropriately and controlling for the best factors that we can, including from, right, like a biopsychosocial, sociocultural context as well. So these are things we all do clinically, but also places we have a stake in terms of how we're communicating with transplant groups, as well as neuropsychology groups for these populations. And then, as I mentioned, it's not necessarily likely that we will see a lot of amnestic profiles in a pre-transplant population. Certainly post-transplant, as people age, we're beginning to see that. But there's this idea that there's potentially an enhancement with end-stage organ function of pre-existing vascular disease that can actually accelerate the aging process. And so as we're doing that and decreasing cerebral blood flow and oxygen, potentially that's where we're seeing some of this on neuroimaging and what that can mean at the time that we're meeting them at end-stage organ dysfunction. And then back to assessment and intervention, what that means post-transplant. Might these be patients where we want to recommend regular follow-up at intervals while they're awaiting transplant, and then post-transplant to monitor for any decline? So unique considerations for neuropsychologists. With kidney, dialysis is huge. So if you're in end-stage kidney disease, what that means is you rely on dialysis or transplant to survive. And because there's just not enough organs to go around, many of our patients find themselves on dialysis. At our center right now, the wait time on dialysis before kidney transplant for a deceased donor transplant is around 6 years. So that's an incredibly long time to be waiting and living on a machine. You can see here with hemodialysis, what happens is you have a fistula or a graft, which allows basically a long needle to go into your arm and start to clean out your blood. You do that anywhere from 3 to 5 times per week, typically at a dialysis center. And you go in, sit for your 3 to 4 to 5 hours, and then leave. So a lot of times we talk about it like, a part-time job that you show up for, but a full-time job in terms of how you're recovering. It can be incredibly hard to stay awake and feel like you have the energy and focus to continue the remainder of the day. Oftentimes, what we prefer to do for hemodialysis patients is ensure that we're testing people on their off dialysis day. So typically it's Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. So trying to pick one of those days in between, and not necessarily the day, but that's their second day without dialysis in the 7-day week. With PD, this is where the solutions are put into the belly, and then overnight, typically, they remove the toxins via the abdomen in that catheter. And that's on a machine at home. That's typically done daily. So figuring out a time that's most appropriate cognitively to do testing, we just kind of have to be flexible, but would encourage folks to try and get to know what their patients need and when they tend to function best, and schedule a time that works with dialysis. Uremic encephalopathy is also something of consideration. So sometimes when we're evaluating patients and I get feedback, hey, something's just not right with this person, they don't seem to be picking up on things, and they're not yet on dialysis, but they're at very late stage 4 of kidney disease, I may say, why don't we get a sense of when dialysis may happen? And if it's pretty imminent and testing can wait, we're not looking for kind of a particular question to answer right now, let's hold off. Let's try and see if we can push it at least a few weeks for them to get started on dialysis and have stability with dialysis, and figure out how much everybody's taken off with those sessions, so that on the day that we do see them, they're at their relative stability on dialysis. With liver, again, etiology matters. So we want to have a great sense of what is causing their liver disease from a hepatology perspective, but also from the patient's perspective. So just because alcohol may not necessarily be the etiology doesn't mean that I don't ask those questions and conduct a really thorough evaluation. And then really trying to delineate how much of the presentation might be due to liver-related dysfunction and impact on brain versus liver dysfunction due to those comorbid conditions, things like alcohol or a viral picture. And then again, back to HE, we really want to only be testing as appropriate when there's appropriate orientation and alertness and ability to participate. So that would ideally be the minimal HE picture, so covert HE or less. Certainly, as we start to see more pictures that look like overt hepatic encephalopathy, we can have conversations with the team about what the question is and if it's appropriate for us to get involved. With heart, heart can be complex. So again, there's just not enough organs to go around, and there's lots of ways to get to heart failure. If there is primarily left ventricle decompensation and problematic functioning, LVAD can be an option. And what that is a left ventricular assist device. It's a machine here that's placed around the heart, and there's a drive line that powers it that comes out through the belly. So there's lots of dressing changes that come with this. The driveline is connected into what's essentially a little computer that's run by a power source, so a battery pack. This is presenting a man who's wearing it more like a vest. Some women prefer like a purse or something that they can kind of hold like a satchel. And then, you know, this is a lot of lifestyle limitations. So we'll touch on lifestyle for transplant, but with LVAD, it's, you know, no exposure to water. So our fishermen and women, and taking baths and swimming, even showering for a period of time and standing underneath the water, those are things that are just not possible anymore. There's ways to get around that and try and modify quality of life, right? Like fishing from the shore. But those are conversations we have to have with our patients. Certainly one of the big risks is increased risk for stroke and bleeding. So this is the device that's pumping the blood now for the patient. And so we're managing a lot in terms of INR, how thick or thin the blood is. That comes back to adherence as well. Are we following recommendations and taking medications as recommended, and helping to manage that risk? And then there's certainly a lot of disparity in terms of access to transplant for all of our organ populations, heart in particular. So the underserved being folks who have identification from racial and ethnic minorities, primarily our Black patients, which we know stand for other things. And so, you know, these are folks who are likely to get referred too late, or even determined to be LVAD candidates versus heart transplant candidates. And so lots of work is going in to figure out not just why those things are happening, because we know that they are, but to figure out interventions at different courses of the disease progression to help intervene on that. And then lung, we talked about sarcoidosis before, but this inflammatory condition where we know that it can also impact the brain. So some organ transplant centers, if there's a presence of neurosarcoidosis in the brain at all, it may make them ineligible for transplant. But this certainly has indications for what we as neuropsychologists may consider in terms of assessment and recommendations. Other things to think about: COVID-19 infection. We're all asking these questions now. I try and do a pretty thorough deep dive just in terms of clinical chart review and asking the patient questions. So as we can start to track that data and identify if these things are contributing potentially independently, or if it may be an exacerbating factor in the picture. COVID-19 has certainly led to organ failure for many patients seen in the last few years, and not just for lung. So those are some interesting etiologies as well. And then, as we always think about, right, so premorbid cognitive ability and learning disorders, that is simply just ability to learn and cognitive resources. That does not necessarily mean that it's cognitive decline. And so we often have to make that very clear to our medical teams, what the patient is capable of versus potentially not capable of in complex medical care management, and what resources will be really helpful for them. And then, because we're talking about adults here, thinking about our emergent emerging adult populations, that they may be attending school or transitioning to work or hoping to work, and thinking about how our neuropsychological assessments can support them. So I just want to sit for a moment and think about what it means for a patient to come be evaluated for transplant. Okay, so at our center, the patient comes in for an evaluation, and it's typically, a 3 to 4 hour visit, and they meet with lots of multidisciplinary team members, and they learn about all these risks, right? So rejection, your body can reject that organ even if it's a perfect match for you. It just knows it's not yours. Immunosuppression. So we have to turn your immune system down just enough so that we're not having your body fight off that new organ. And what that means is lots and lots of medications to take. And in the beginning, it's really, really high doses, and you're just not going to feel like yourself, right? And then we also talk about the benefits. So you could potentially have longer life and improved quality of life and, hopefully feel like yourself. Sometimes we also say that there are potential for improvements in cognitive function, right? Which is a very measured way of saying that it could or couldn't happen. But it all depends on the individual and how they're presenting initially and what their expectations are. And we like to say that transplant is predictably unpredictable. We just don't have a crystal ball to say how this is going to work out for somebody. And, we can see post-transplant that, like with liver transplant, for example, they can look different depending on etiology, but what we tend to see the story tell us is that those who have fewer minimal HE episodes pre-transplant tend to have better improvement over time, but they're just not necessarily functioning where we would expect them relative to the general population. With kidney transplant, we can see post-transplant, some episodic and verbal declarative memory can normalize. Psychomotor speed, verbal fluency, visuospatial abilities, they still tend to be below that of the general population. And oftentimes there's just some mood dysfunction that can happen as well. With heart transplant, several studies have shown that heart transplant can improve mental flexibility and attention and memory. I mean, if you think about it, we're just perfusing more. So some more things can come back online. However, about 45% of heart transplant recipients demonstrate persistent cardiac impairment post-transplant. And then with our lung patients, the evidence is kind of mixed. The story I'm seeing from a study by Hoffman and colleagues is really, it kind of depends on age. So they found that executive function and verbal memory scores were within normal limits, but they were slightly better in the younger folks. We saw it get worse with our older patients from that sample. And then interestingly, back to intervention, pulmonary rehab post-lung transplant has been shown to improve cognition among those who were transplanted for COPD. So thinking about what risk factors can be and how we can modify those, that actually has a space to consider in terms of cognition and what that could mean for our patients' day-to-day functioning. So take home, just in terms of what we know so far about predictors of post-transplant cognitive function: age, severity of organ disease conditions, so their EGFR, dialysis duration, if they had Hep C, for example, other organ dysfunction that's on board, this idea of prior events. So whether it's overt HE events in liver transplant and liver disease, number of encephalopathy episodes, prior cerebrovascular or cardiac events, the presence of cardiovascular disease, and then immunosuppression itself. So CNI, the calcineurin inhibitors, are the primary class, and we do see that those can impact aspects of cognition, Our lung transplant patients are on them at pretty high doses for about a year, and that's the longest of all the organs. So if you're seeing a post-lung, that may be something that's going on. Cytomegalovirus, so that has also been associated with increased cognitive impairment, and this was a study of folks over 65 post-transplant. And then the predictably unpredictable stuff. So if there's organ failure, things aren't working as expected, we may also see some ongoing neurocognitive dysfunction. So I think in my last couple minutes here, I just wanted to leave a take home about what transplant neuropsychology is, but also what I hope it could be and the way I'm trying to practice. So we could do a whole talk just about the history of transplant psychology and pre-surgical evaluations and assessments, right? Especially for candidacy for transplant. I tend to practice with this goal of balancing objective assessment of deficits, which we get from neuropsych testing, with identification of strengths and opportunities to optimize their functioning, which is, I think, what we strive to do as neuropsychologists, see these objective data in the context of the full clinical picture. You know, we do things like seeing how much they recall about transplant education and making determinations about health literacy and adherence and trying not to overpathologize what's in our chart, which we know can be biased, and particularly for our minority patients. And then I think about all the time, transplant could be a potential treatment for cognitive dysfunction, right? And so how can we determine what's modifiable and then help to modify that for our patients as they're pursuing access? So, you know, this is the way that I think about our transplant landscape and what I've tried to do. I've tried to shorten testing batteries and think about really what matters most. Where am I going to get the most bang for my buck when I have a patient come in to see me for an evaluation? So strengths, weaknesses versus what are the exact differentials, role of health literacy in their cognitive functioning and their behavioral functioning in terms of adherence. And then thinking about how to structure how I'm billing to actually allow me to do some of that work. So I build in hour-long feedback visits with my patients, and I try and build in opportunity for short-term intervention visits as well. Hey, we talked about compensatory strategies for helping with medication management. And I know you're having a lot of stress at home. Let's really, you know, continue to work together and think about how we're going to put these things in place. And I make very, very clear recommendations to our medical team about what follow-up could and should look like and what those intervals could be. Our patients all have nurse coordinators that read all the recommendations and put them into practice. So I like to be really clear with our team about what that means for me to keep working with someone. With my patients, I like to talk about where the patient can take control with their health. So if we're talking about managing health behaviors or that word adherence, how are these opportunities for the patient to take control of something that's out of their control? Our teams will talk about exercise and abstinence from substances all the time. I talk about it as ways to promote brain health. You know, hey, we actually know the longer you're abstinent from alcohol, here's the way that your brain can begin to recover itself. And we're already seeing that for you, you're noticing XYZ that you told me in the interview. I like to link everything to what their identified health goal is. So for some people, it's to feel better physically. For others, it's to be around for their children. And so if they're having to make lots of changes to their health, I'm also implementing a lot of like motivational interviewing techniques to, wow, like that must be great for your kids to see that now we have to meal plan and manage nutrition in this way. And then definitely for those with limited health literacy or transplant knowledge, and even for memory recall difficulties, lots of feedback, repetition, reinforcement of themes, and framing those to our physicians as well. This is the kind of messaging I'm sending to our patient. Are there things that you're talking about that I need to make sure to touch on too? Okay, and with that, I can take some questions. I know I'm close to time here.
Thank you so much, Dr. Price. We do have several questions. Think this talk was excellent, and it's started a wonderful debate. Or not a debate, I guess. It's sparked a lot of excellent questions
Good.
on the side. So, since end-stage organ failure leads to cognitive impairment that may impede adherence to complex medical regimens, are there any red flags or absolute contraindications in those neuropsychological profiles that you think would be important to communicate to the pre-transplant committee?
Yeah, so I will answer that a couple ways. So our transplant communities, so by organ population and the publications that um, are published for those different organ population groups, typically dementia is determined as an absolute contraindication. If we're seeing significant deficits, right, that come to sort of an amnestic profile, or significant functional concerns, in addition to neuropsychological functioning that's indicative of something more like a major neurocognitive disorder, I try to present those as, again, balancing those objective risks. And maybe there just aren't a lot of protective factors. And maybe the risks for this patient might outweigh their expectations, right? I want to get back to work. I want to be able to live independently. And so really trying to balance not just the objective data and diagnosis, but what that means in the context of the landscape, that picture of the patient, their expectations, what's involved with lifelong management for transplant. Do they have the social support and capability to do that?
Mm-hmm. That makes sense. Which, kind of highlights how different all of these assessments have to be and how you do have to tailor every assessment to those specific patients and to their specific presentation. So I know this is kind of a broad question and it might be hard to answer, but you're the expert, so if you could give us even just a hint. Um, we wanted to know if, given the patient's medical status prior to transplant, how do you tailor your evaluations? For like example, how long would you test for? What cognitive abilities would you focus on? Things like that.
Yeah, I have developed, and I didn't get into a lot of detail with this talk, but I developed and direct our transplant neuropsychology clinic here at MCW, and that's within the Department of Surgery. So I'm embedded in our transplant clinic, kind of rubbing shoulders and heating up my lunch with our surgeons and physicians and nurses and pharmacists and everybody. And so what that means to me is I'm seeing people when they're coming to this clinic and they're headed to something else. And it just doesn't make a lot of sense for them to be here all day. And even just thinking about physically what their pictures look like, we're not going to get our best bang for the buck, right? If we're doing full WACEs, if it's not really indicated. So I tend to do, I call it a 2-hour battery. Sometimes it's a little shorter, sometimes it's a little longer. It depends on the patient. I tend to keep it more heavy focused on the things that have more direct implications to day-to-day functioning post-transplant. So certainly executive functioning, memory in different domains. Also because a lot of our patients have limited quality of education and educational background, I want to see where they can function best, back to those strengths versus weaknesses. And then I like to also, get things like simple attention and processing speed, because some of the feedback that I do provide to our physicians is, this is somebody who can probably remember, X number of bits at a time, if I'm able to see that pattern throughout the battery of performance. And they tend to remember, right, like stories better than lists or pictures better than anything verbal. And I just try and make it more adaptive to how a physician might interact with the patient. And then certainly how I provide feedback to the patient too. Here's how you did on that test. Do you remember this one? We kind of had to match cards. Well, here's what we think we're getting at with that. Stuckness versus being able to solve a problem more independently. So really trying to make it more conversational in terms of how their approach was in the 2-hour battery and what we saw come out on testing.
Gotcha. And this is kind of a piece of that question. Dr. Lapointe asked if there's a particular battery or if there's any particular measure that you always like to include, maybe an R-bands, WAIS, trail making, PAI, anything like that.
Yeah. I will just start by saying I don't do any personality testing with my patients. I do a pretty thorough interview. I would have to say my number one thing that I get that I think is the most helpful is actually just a really good, solid clinical interview. It's anywhere from, 75 minutes to 90 minutes, lots of chart review. I have collateral come in. We talk about more than just a neurobehavioral status exam. They tend to see me after they've seen the rest of the team. So I'm asking them, what do you remember about transplant? And what do you remember learning? And then asking in more of a confrontational recognition way, do you remember talking about these things? Neuropsychologically, in terms of tests, we have used the R-bands, and that tends to be more for patients who I'm kind of questioning more of an encephalopathy kind of picture when they're presenting on the outpatient side, or if we're needing to do something more inpatient, that's more of a quick screener. But I tend to rely on more those really solid and multiple memory measures, executive measures. I do like the Wisconsin with this population, if we can do it. And then many aspects of the WAIS and trails.
And Dr. Price, I realize we're at the top of the hour. Do you have just a couple more minutes to answer some questions? Otherwise, we can cut it off. Okay. Absolutely. So we also wanted to know how you collaborate with your multidisciplinary colleagues when you're trying to figure out when to schedule. That can be a huge barrier for a lot of us, especially working in academic medical centers. I know you kind of alluded to this, like being able to be embedded in the team, even just being there to warm up lunches with them. So that's a wonderful part of being in that team. So do you think, like, speaking a little bit about how that might help or maybe even hinder with scheduling their appointments?
Yeah, I think, I'm in a unique position in that I'm embedded, and I certainly recognize that. I think part of this needs to be collaboration. So if we're the experts in neuropsychology, we should have a seat at the table when it comes to working with our medical teams and getting a sense of, really what is the difficulty with patient care. So I often encourage folks interested in transplant, try and attend those selection committee meetings, ask for meetings with a medical director or surgical director, introduce yourself, talk about what you're interested in and how you would like to collaborate in patient care. Many transplant centers have their own health psychologists who work with all of those patients and conduct the majority of the psychological evaluations. So it's important to have collaboration and working well with those providers too. In terms of scheduling, I would just ask, what are the days that you tend to see your patients for follow-up? What are pre-transplant consult dates? What are post-transplant dates? Who tends to see the most in terms of the physicians? I kind of always just give a 4-hour block because it means I could do a longer interview if I need to. We could do at least an hour of testing and they can take plenty of breaks or do their labs or show up late because that happens. So if that's how we want this to look, what could that look like? I think the other thing we could also expand with our transplant neuropsychology specialty and the profession, if we're going to be integrated and have dedicated time with a certain service, is maybe more of that kind of on-call picture. So if there's a clinic that's going on and it's a post-transplant clinic, and let's say it's kidney and there's lots of older adults who are coming in, might we want to have a stake in some of those visits and being available to do quick screeners or clinical interviews, determine if longer testing is needed, and talk through what that would mean in terms of scheduling, as well as professionally, how might we bank our time to be able to do that effectively for the team.
Yeah, thank you very much. And then just one final question. We wanted to know a little bit more about assessing for health literacy in this population. That was something that you had alluded to in your presentation, but we weren't sure if you had any more concrete strategies or interventions even for supporting health literacy and trying to assess that in these patients.
Yeah, there's a lot in the pre-kidney transplant literature, health literacy, mediating relationships with cognition. I know that comes from a lot of Dr. Wood's HIV work. In transplant, health literacy in itself is a risk for limited access to transplant, waitlisting for transplant, receiving transplant, and those things are actually worse for our underserved population, so minority population. So I try and find a balance of not over pathologizing poor health literacy, because I think we know when we see it. The other thing is, we as transplant teams do not formally assess health literacy as part of the transplant evaluation process, but we put a lot of labels in the chart about limited health literacy. So I try and be just very objective about what I see. There are certainly measures people can use, the realm. Some of these have also been developed for transplant. The thing about health literacy measures that I have always struggled with is that they rely on reading and educational background, and we can answer those questions in other ways as neuropsychologists. And I can gather some of that information from a good clinical interview and record review in collaboration with my team, what's going well, what isn't going well. And then I think the other piece about health literacy is, depending on the measure, we're looking at different things. Some health literacy is truly reading ability and familiarity with health words. Other is like health decision making. And other health literacy measures are really just kind of rote knowledge of what to do in a health situation. So all of that involves cognitive control. For what I do in transplant, I want to make sure they know the basics about their own disease. So if the patient is presenting for kidney disease due to diabetes, well, what are you supposed to do to manage that? Are you supposed to check your blood sugar, and how often? And are you on insulin, and that dose? Are you supposed to make a decision about it? You tell me what we know. And if there's gaps between that patient's ability to express it, know it, if I'm giving them hints, and what I'm seeing in the chart, then I tend to have a better sense of where we're at with health literacy.
Thank you very much. We had more questions, but I realized that we've already gone almost 10 minutes over. So I want to be respectful of everyone's time. So yes, thank you so much for this lecture. I just want to remind everybody that we have 2 lectures next week. So please join us again next week. Monday is going to be functional mapping in epilepsy using different methodologies. And that'll be presented by Dr. Bearden and Dr. Winston. And we'll have a makeup lecture, which will be on Tuesday the 19th, entitled Creativity in Awake Craniotomy, a patient-centric approach, which will be presented by Dr. Bender. Thank you again very much, Dr. Price, for your presentation. It was excellent, and I certainly learned a lot. And join us again next week. We'll see you all soon. Thank you.
Thank you.